Hello, everyone. Welcome to this YouTube site about patient education before, during, and after knee replacement or total knee replacement. I'm Dr. D.Graybill. This is my second video topic after my overview. On this site, we will populate several more gradually. This pairs with a book I've written entitled The Proactive Approach to Total Knee Replacement. It focuses on a data-driven guide to reduce complications and increase the odds of an optimal recovery. It's published in e-format October of 2025. The print format, I believe, will come in December of 2025. The video series is to supplement the book. I'm picking just a few select topics out of the book and hopefully give a little bit different perspective and enhance the experience. So one of the first questions that I get from patients, I'm now retired, but when I was in practice as a very active total hip and total knee surgeon, was what is arthritis? So we're going to cover that and some helpful terminology in this video. So the book is available on Kindle, on Apple, on Barnes & Noble. It's published by BookBaby, and I encourage you to pursue that. If you're considering knee replacement, it has a number of unique aspects to it that are not in the other literature that I could find for patients, specifically things to optimize your medical, physical, and lifestyle prior to surgery, which can reduce complications and improve recovery, and then also discussion on patient satisfaction and outcomes, which aren't present in other books that I could find. So I encourage you to reach out for the book. I favor the ebook version, although the print version has other aspects that are helpful. So onwards. So this is an arthroscopic photo of a knee. The meniscus has been partially removed. If you look at the lower center portion of this photo, that is exposed bone. So if we go to a normal knee joint, we have the femur, which is the thigh bone, the tibia, which is the shin bone, and the kneecap called the patella. And in a healthy knee, each of those are covered by a surface called articular cartilage. And that articular cartilage is what's damaged in osteoarthritis. This results in thinning and roughening, and eventually the bone touches. There are bone changes that are associated with this that involve thickening of the bone, which doesn't work as a shock absorber as well as it should, and therefore even more stress is placed on the cartilage. So osteoarthritis is a relentlessly progressive degenerative process. Other types of arthritis can lead to this. For example, rheumatoid arthritis is a biologic process which damages the cartilage. But once the cartilage is damaged, some of the same pathways proceed common with osteoarthritis, and the same thing is true with post-traumatic arthritis. If you have an injury to the knee, a fracture into the joint, or a severe injury, such as completely tearing the meniscus or ACL tear, there is damage to the cartilage, and the knee will become arthritic over time. The rate of progression is quite variable from patient to patient, but it is a relentless process. So here is a microscopic view of the cartilage itself. The joint surface would be above, and the cartilage and bone would be below. There is a membrane over this very smooth surface when it's healthy, and that membrane is low friction. It is lubricated by the joint fluid, and it also has a very significant shock absorber function. So if you think about maybe you're running or you jump off the back of a pickup on a healthy knee, what happens? So when we land on the ground, at the cartilage level, there's a lot of water in the cartilage. The membrane is partially permeable, so when force is applied, the water is pushed out of the cartilage, and that absorbs some impact. When the load is taken off, there's an ionic draw that draws the water back into the cartilage, and it kind of reinflates. Underneath the cartilage is a thin layer of solid bone called subchondral bone, and that's kind of flexible. So it will give a little bit, again absorbing some of that stress. Underneath that subchondral bone is trabecular bone, which is kind of like scaffolding. And those can also bend a little bit and absorb some of the stress. So that's how cartilage functions when it's healthy. Osteoarthritis starts with a breakdown of the membrane. It's combined with a thickening of the bone. And both of those events lead to a lessening of the ability to absorb stress. So I think, to the best of my understanding of things, once that membrane starts to break down and we get some cartilage wear, really it becomes irreversible at that point. There are a lot of non-surgical treatments, but none of them that I have seen have clearly demonstrated true regrowth of the natural cartilage. There's repair processes that can happen. Stem cells, it's not completely clear how they affect it, but I don't think there's any evidence, once there's substantial arthritis, that non-surgical intervention regrows normal cartilage. There is a study going on stem cells that may delineate that, but I think at this point that doesn't appear likely. So here's a knee structure. The knee is a modified hinge. By that I mean it doesn't pivot around a point. As it bends, it glides and rotates. The bones involved, again, are labeled here. The femur is the thigh bone. The tibia is the shin bone. The patella is within the musculature of the quadriceps. It's the main and really only extensor of the knee. That's what straightens the knee. The blue surface you can see on this slide on the femur is the articular cartilage, which is normal here. The meniscus are two disc-like structures that make the joint fit together better because the femur is more curved than the tibia. And if we don't have a meniscus, there's more or higher surface contact or surface forces. So that's one of the reasons if we've had the meniscus removed or damaged, we're more likely to get arthritis because the joint surface stresses increase in a patient without a meniscus or with a large torn meniscus, with or without surgery. So here is an x-ray of a knee. Standing knee x-rays are the main tool we use to evaluate, grade, and follow knee arthritis. The clear space you see between the bones on the x-ray on your right, which is the left knee, labeled L. You can see space between the bone. That is the thickness of articular cartilage. Because it's weight-bearing, the forces are forced together, and any space there is actually how thick that articular cartilage is. So on the left knee, it's a little narrowed. So I would describe this as mild narrowing. On the inside, which is the part between the knee and the outside, we call lateral. That's the outside of the knee. When we look on the knee labeled R, which is on your left, the medial side, which is the inside near where the knees would touch, you can see the bone is touching. There are also spurs. That's the bone adjacent to the normal bone that has formed. Those are called spurs or osteophytes. That's a reaction to arthritis. And we can see there's no joint space remaining. So that would be advanced arthritis. Again, once we get to this level of disease, non-surgical treatment becomes less effective, but sometimes can still be helpful. And over time, if you follow the knee on the left, it will eventually become like the knee on the right over some time frame. What's kind of interesting, however, is that one patient might proceed relatively rapidly, whereas another patient might take a decade or more to get there. And that is not directly related to how active a patient is. I try to encourage patients to stay as active as possible with arthritis. It isn't like there's just so many steps left before the knee is completely worn out. Activity is a very important part of life. And if we become inactive, we become deconditioned. It's very hard to become reconditioned, and that really isn't in your best interest. There's a nice topic in the book covering this, but that's an X-ray view of osteoarthritis. Again, it's relentlessly progressive. Here is a knee labeled R. It has some narrowing on the inside of the knee. It's kind of maybe in the late mild to early moderate range. It will eventually progress. I believe this is my knee, and eventually I had a knee replacement. So one quick comment on weight loss. Weight loss is the only intervention that is well documented in the literature to show a slowing of progression of arthritis, but it doesn't stop it. So if you are very heavy and have early arthritis, weight loss is to your benefit. Weight loss has lots of other benefits, but if your knee is completely worn out, there isn't a great correlation with weight loss and symptom relief. There is a great correlation with weight loss and reduced postoperative problems like infection, etc. So I do encourage weight loss for patients as they can. So hopefully you found this interesting. There's a lot more information in the book on this topic. And this kind of ends our discussion. Again, I encourage you to look to the book. Again, available on Kindle, Apple, and Barnes & Noble, as well as the publisher BookBaby. And I hope you find this topic helpful, and we'll move onward with our video series as it's created. And again, have a wonderful day. Thanks again for your time. Bye now.